as we review this case, my initial observation is this type of presentation is becoming increasingly rare. Only about 5% of patients present with de novo metastatic breast cancer in the United States. And this is largely due to progress we've made in getting the word out about the importance of breast self-exams and screening mammography. So patients tend to be diagnosed at an earlier stage. In this case, the patient has HER2 positive breast cancer, which we know accounts for about 1 in 5 or 20% of all cases of breast cancer, and can be very effectively targeted with anti-HER2 therapies. These treatments have changed the natural history of this disease. In terms of prognosis, this patient is likely to respond very well to therapy, given that she's treatment naive in the early stage setting without the opportunity for resistance to have emerged. I would say it's standard to do HER2 testing at the time of diagnosis. The site of biopsy is important here, as oftentimes there are difficulties with bone biopsies, especially with false negative results on bone biopsies due to the process of bone decalcification. Here, the patient had a pulmonary nodule that was biopsied, so I would say this would be considered fairly reliable. One may consider repeating a biopsy at some point in the clinical course when the patient is not responding for the duration of time one would expect based on pivotal trials with the therapies that are being offered. In this case, she certainly did respond on average, what we saw in the Cleopatra and Amelia trials in terms of her responses to first and second line therapy. So I don't know that I would stop at this point to repeat a biopsy. But there can be instances in which there is tumor heterogeneity or a change in the HER2 status. And another reason I'd say to repeat a biopsy may be to perform NGS testing, which may guide participation on a clinical trial.